Good evening, ladies and gentlemen, and welcome to the CME sponsored by the Emirates Cardiac Society and Pfizer on anticoagulation in special populations. We have two important speakers tonight talking about special populations. Our first speaker is Dr. Abdul-Majid Zubaidi. He's a consultant cardiologist and current president of the Emirates Cardiac Society. He will talk about anticoagulation in ACS patients. Dr. Abdul-Majid.
Thanks, Dr. Weil, for this kind introduction. I'm just going to share with you my presentation. Let me get in. Is it there?
Yes, it's there. Go ahead.
Excellent. So thanks, Mr. Chairman, and thanks to all the audience who are online watching us and for their time. So I was asked, or I was given the task to talk about the management of patients on NOACs undergoing percutaneous intervention. Basically the patients with the population that I'm going to talk about is patients with atrial fibrillation. As you can see here on the screen, these patients are at risk, as we all know, depending on the risk factors that they have. They're at risk of stroke and transient ischemic attacks. Of course, to prevent that risk or to minimize that risk, oral anticoagulation is indicated, and there is a lot of data that proves that, and it's superior compared to dual antiplatelet therapy. So oral anticoagulation is the best practice for patients with AFib, and the anticoagulation that we know is vitamin K antagonist, and recently over the last few years, we've been switching to factor 10A inhibitors and direct thrombin inhibitors, or the NOACs. On the other side, we have the population of PCI, or acute coronary syndrome, and myocardial infarction patients, coronary artery disease patients, who are at risk of MI and stent thrombosis. This PCI population, the evidence to reduce the events in this population is with dual antiplatelet therapy. And, you know, there is a lot of data and controversies around the duration of antiplatelet therapy or dual antiplatelet therapy in this population. And obviously it's superior to oral anticoagulation treatment. Of course, the list of antiplatelets we're all familiar with. Aspirin is have been there for long years. Clopidogrel, prasugrel, and ticagrelor. In UAE, we don't have prasugrel. Now, the challenge that we face, and I face with my patients, is the AFib patients who requires a PCI, and that's the topic today. So AFib patient who requires a PCI is about 20% of PCI population. So if you're in a cath lab and you do PCI, about 20% of your patients will have atrial fibrillation. So you have to deal with this scenario: oral anticoagulation, dual antiplatelet therapy, or what we call a triple therapy, to minimize the risk of stroke and the risk of stent thrombosis. The challenge and the difficulty is the bleeding with this scenario. So AFib, PCI is not the best combination we would like to have. So the triple therapy, what we call triple therapy, is includes, as you can see on the screen, I mean, here we have the coagulation, or a simplified coagulation cascade, and then here is a platelet adhesion and aggregation cascade, and the different antiplatelets here and the different anticoagulants here. Of course, we have here the factor 10A inhibitors, and dabigatran, the direct thrombin inhibitor. So the triple therapy, what we call a triple therapy, is one of the DOACs plus aspirin plus one of the P2 Y12 inhibitors, which is mainly clopidogrel anticoagulant in our practice here in UAE. So the selection of any of these medications, or to decide about which one you go with the three and for how long, is a real challenge. And as I said, we see it so frequent in the cath lab, and we have to write that recommendation in our reports when we finish the procedure. So I'll give you two scenarios here just to get the feel, and then we'll move to the evidence. So a 76-year-old female, history of chest pain. She's diabetic, hypertensive, coronary artery disease with the PCI. So she got a past history of PCI. She got a chronic atrial fibrillation and on aspirin, warfarin, interestingly, still on warfarin. Someone kept up on that. ACE inhibitor and stat. Lung congestion, heart failure. And she comes with anterior T-wave changes, elevated troponin, and she undergoes a PCI to the LAD. So now we got person who got a chronic AFib, multiple risk factors, on undergoing a PCI with an LAD stent. The good part is her LV function is good. So that's one scenario. So what is the recommended antiplatelet and anticoagulation? The second scenario is a 55-year-old male presents with acute chest pain, paroxysmal AFib, and that's his physical exam, unremarkable. And also anterior ST elevation, got an LAD stent and a PCI to the circ as a staged PCI, and also a PCI to the right coronary artery. The echo reveals ejection fraction of 40%. So the question usually is, what would I recommend in the report after I finish my PCI? What kind of antiplatelets, clopidogrel, ticagrelor, what kind of anticoagulation, warfarin or the new anticoagulation drugs, and which one of them? And the other question is for how long? So that question is something that I need to assess based on the risk factors. So we all know all the different risk scores. We have the CHADScore that is developed for patients with atrial fibrillation, and hopefully most of you are familiar with, when it helps you predicting the risk of TIA and the risk of stroke in your patients with the atrial fibrillation, and also the risk of, you need to understand the risk of stent thrombosis. So for those two patients, the first patient, based on the CHADScore, is at high risk. Multiple risk factors from the CHADScore indicates that she is at high risk of CVA. On the other side, you want to understand the risk of stent thrombosis. We implanted stents in these patients, and we know we need to know how high is that risk, because that will dictate or will help us in deciding which antiplatelet and for how long. So the decision on stent thrombosis, every patient is different in terms of risk of stent thrombosis, and patients who are at high risk, it can be related to the patient himself because of multiple risk factors, because of a compliance, because of naturally resistant to any of the antiplatelets, especially the clopidogrel or the aspirin. It can be related to the device, the type of stent, the length of stent, and I will show you in the next one of the next slides some of these criteria. The procedure itself, so technically the stents can be under expanded or not opposed very well. The lesion is not stented very well, or edge dissections, and so on. So you can see these risk factors here in a kind of more details, and this is part of an article published last year in JACC, and it's a state-of-the-art review by Capodanno, who's well known in the antithrombotic antiplatelet field. And I would recommend that, the people who are interested in this topic to read it. So he talks about those high risk driven thrombotic risks, as you can see. So prior stent thrombosis, puts you at risk, or puts that patient at risk of thrombosis. Stenting of the last remaining patent coronary artery, because that's a high risk patient, not a vessel, but the patient becomes at a high risk because that's the last artery that feeds the heart. Diffuse multivessel disease, chronic kidney disease, 3 stents or more than 3 stents, bifurcation stents at a high risk, long stents, and chronic total occlusion patients. On the other side, we have to assess the bleeding risk. So we want to understand the risk of thrombosis, but also the risk of bleeding. So bleeding risk, as you can see, multiple risk factors for bleeding, and I can tell you that the literature is full of different risk scores, or scores that helps assessing the long-term bleeding in patients. So multiple risk scores developed over the years. The most famous is the precise DAPT score, but it just tells you that this field is very important, because bleeding by itself is a major predictor of mortality. Those risk scores does help us in making also that decision. Of course, the risk scores are important, but I can tell you, it's a lot of time it's your clinical judgment and your assessment of the patient. Elderly patients with different comorbidities, anemic, low platelet patients, those who had a history of intracranial bleed, those with the bleeding history, and those who are already on different anticoagulants or different medications that enhance bleeding are, of course, at a major risk. And these patients also should be educated on these factors for a future counseling when you're putting them on these medications. So it's a very dynamic a decision. And it's not just risk scores that we depend on. I mean, there's a multiple, as I showed you, to assess the thrombosis. We have the CHAD risk. We have all the different risk scores that we use, and also the bleeding risks. All these risk scores does help us, but at the end, all these different risk scores, you need to have an evidence-based practice that puts everything together: your clinical judgment, the best evidence, the patient's different factors, culturally, compliance, affordability, insurance. All those factors need to be plugged to make the decision of the regimen that you're going to put your patient on. So I hope it's clear now that the decision is not so straightforward. You need to have a proper assessment of the risk and the risk of thrombosis, of coronary thrombosis, of stroke, and the risk of bleeding. This slide comes out of the European Society of Cardiology, and it's the most recent ACS non-STEMI guidelines in 2020. And they looked at, as you can see here, so AFib patient undergoing PCI for a non-STEMI. So here, you're not talking about STEMI, we're not talking about the stable patient. So those also you have to decide about their risks in terms of thrombosis also. So, but the guidelines here, the default strategy is a triple therapy in hospital, and then a dual therapy with a NOAC and a single antiplatelet, preferably clopidogrel for the rest of the year, and then a NOAC alone. Higher bleeding risk patients. So as I showed you with the different risk factors for bleeding. If you feel that your patient, or if I feel the patient is at high risk of bleeding, then I usually switch them again to a dual antiplatelet a dual therapy, NOAC and a single antiplatelet for after discharge. High ischemic risk, but the bleeding risk is not high, then a triple therapy can be continued for a month. And I will show you more evidence around this factor, for how long. The challenge is for how long should you continue the aspirin. So these recommendations comes out of multiple trials published over the last 3 years. And you can see a summary of these trials in this slide. So we have 4 major trials. Actually, there's more than this, but we picture the 4 major trials. The first one is the residual PCI, and that looked at dabigatran 110, 150, and a vitamin K antagonist, warfarin. And this is the primary endpoint. Remember, the primary endpoint is a safety endpoint, which is bleeding. The second trial is a Pioneer AF, and that looked at rivaroxaban at 2 dosages, the 2.5 and a 15 milligram, and also vitamin K antagonist. And then edoxaban compared to vitamin K antagonist. And last, which I'm going to focus on or highlight in the next few slides, is the Augustus trial. And the interesting thing in the Augustus is they combined it's like a 2x2. So they 2x2. Sorry, I think I have issue with the camera. I see the message here. I'm just going to work it out.
Doctor, you can stop share and start sharing again.
Okay, sorry.
Okay.
I have a challenge with my laptop. Okay. It's the usual technical thing, yeah? So is my screen still up?
Yes.
Yeah, I think I have an issue with my, there's some sort of a freeze here. Okay, I'm going to stop sharing. Okay.
Do you have a Macintosh?
Yeah, it's a Mac. Wire.
So this always happens with Mac.
Yeah. Yeah, here it says it's not launching. Okay. So I'm going to force quit it and
Doctor, can you leave the webinar and come back again? Just click on leave and come again.
okay. Am I back?
Yes, just open your camera,
Yes, you're
please,
back.
and start the slide.
Okay. Okay, excellent. Back on track. So you have the presentation on?
Yes, we have the presentation. Just click on slideshow and you can
Slideshow,
continue.
okay. Okay, great. Okay, so we're back on track again. Apologies for this, this technical challenge. So back again. So we talked, so I hope I gave you a background on how the decision is a challenge, and I showed you what the guidelines recommend in terms of when you go for a dual, especially with the ACS patients. And now we're moving towards the evidence and where the literature comes from that supports this recommendation and these guidelines. So we talked about the 4 major trials that compared a different regimens, including that included the key NOACs that we know in the market, which is dabigatran, rivaroxaban, apixaban, and edoxaban. And I was, and one of the things that I want to highlight is these trials are recent, or they've been published over the last 2 years in key journals, and they are large trials, more than 2,000 patients at least, for the trials, if not more, like the Augustus. The Redual and Pioneer and Entrust looked at compared the the NOACs to vitamin K antagonist. Augustus had a almost 2x2 factorial design where they looked at aspirin compared to placebo, and also vitamin K antagonist compared to apixaban. And one interesting thing is all of these patients are on a background treatment of clopidogrel. So all of them are, majority, of course, they're on P2Y12 inhibitor, but the majority of the patients, as you can see here, 88, 90%, or 90+% in the rest of the trial is mainly a clopidogrel-based treatment. So those are the trials. Let's go and focus on the Augustus trial, since it's the largest and it addressed 2 questions. One is comparing apixaban to vitamin K antagonist. So the inclusion is if a patient with an ACS or a PCI, okay, and with a background treatment of a P2Y12 inhibitor for more than 6 months, planned, at least the patient can take a P2Y12 for more than 6 months. The majority of patients, as you saw, were on clopidogrel. They excluded those patients who have a contraindication to DAPT or other reasons for vitamin K antagonist, like prosthetic valve or the mitral stenosis. So that's the first layer of randomization. The second layer was aspirin compared to placebo. And this trial's primary endpoint was major bleeding and non-major, clinically relevant non-major bleeding. And then, of course, they looked at other endpoints like death, hospitalization, and other ischemic events like stroke, MI, and stent thrombosis and urgent revascularization. The primary endpoint, and this is by subgroups. Of course, they took some of the patients who were ACS, the majority, and there was about 30% of the patients who had elective PCI. And we know elective PCI is relatively a lower risk patients compared to the ACS patient, low risk for future events, for stent thrombosis mainly. And clearly, apixaban compared to vitamin K antagonist warfarin was superior in this population, AFib and ACS population. The second part was the aspirin, and of course, aspirin was not safe. If you add aspirin to the treatment, so if you're going with the 3 triple therapy, compared to placebo, usually the patients bleed more. So placebo did better in this group. So here there's a breakdown of the four group sets that were included in the trial. So the first group, which was the highest risk group that had more bleeding, or the highest in terms of safety or primary endpoint bleeding, were the patient who took warfarin and aspirin, plus of course clopidogrel. So remember that on the background there's a clopidogrel for all these patients. Apixaban, aspirin, and clopidogrel were the next in terms of bleeding, and then a vitamin K antagonist and a placebo and clopidogrel, and the last was apixaban and a clopidogrel was the lowest in terms of risk of bleeding. So, the best regimen here was the apixaban and clopidogrel dual treatment. Now, we have to remember that this trial was primary endpoint for this trial was major bleeding, was mainly bleeding or clinically relevant non-major bleeding. So efficacy or myocardial infarction, death, or MACE was not was a limitation here. All patients received aspirin during their hospitalization for the index ACS or PCI for at least 9 days or 6 to 9 days before the randomization. So that period of time, the early period, was not addressed in this trial. So you can't randomize or you can't start your patient on a dual treatment from day one. The trial did not address that time period, the hospitalization period. Of course, it doesn't address the optimal treatment duration for anticoagulation and P2Y12 because the trial ran only for 6 months, and you can't use the results for a longer term decisions. So based on those trials and based on the Augustus, I think we can be confident that in terms of safety, that a dual antithrombotic therapy, which includes one of the anticoagulants, because we saw all the 4 trials included either one of these anticoagulants plus clopidogrel mainly, because the TICA and the rest of the medications were not, or the antiplatelets, the P2Y12 inhibitors were not heavily presented in those trials. And we can, with some confidence, we can drop the aspirin for these patients, AFib patients with the PCI. But how confident are we to say that, double antithrombotic therapy is enough? Actually, there's a multiple meta-analysis and systematic reviews that came out over the last year, looked at these trials, and you can see here, this is a systematic review published at the European Heart Journal last year, and they looked at the bleeding. So bleeding favors, dual antithrombotic therapy. So if and that's by logic. I mean, dual antithrombotic compared to triple will do better in terms of bleeding. But when it comes to thrombotic event, especially stent thrombosis, there was an alarm here, although the confidence interval is quite wide, but there is an alarm. And this came in other papers. This is I think an editorial at the Euro intervention, and the same thing, bleeding was clear, and there's a benefit of of a dual therapy, low risk of bleed, or when you omit aspirin. But when it comes to stent thrombosis, to MI and death, at least numerically, it's higher compared to dual therapy. This is a meta-analysis, but specifically looked at stent thrombosis. And this was published in JACC early this year. And what they concluded, as you can see, the trials that I showed you early, the Augustus, the Entrust, the Pioneer, and the Renal, so all the 4 major trials that addressed AFib and PCI. And you can see the absolute number, 56 stent thrombosis compared to 30 Stent thrombosis, the same thing here with, you know, I mean, this is, of course, it's a meta-analysis, but it does show a signal of a increased stent thrombosis compared to dual antithrombotic treatment. So this becomes a challenge, you know, stent thrombosis issue with the dual antithrombotic therapy. And unfortunately, it's not going to be easy to conduct a study to look at this endpoint, because we all know now with the advancement in stent technology and procedure, the stent thrombosis risk is very low. It's 1% annual. So to conduct a trial to detect a difference, you need at least a 26,000 patient trial to look at this question. So it is a challenge. So how to proceed? You know, how to decide about, you know, omitting aspirin or continuing that triple therapy for some time, either hospitalization or a 1 month or even a 6-month triple therapy. Again, it's the risk estimation. You have to do that exercise. You have to do that when you're assessing your patient, either after the procedure or dynamic as you see the patients out in the clinic in your follow-ups. You know, so you have to look at the coronary ischemic risk, clinical and chronic complexity. You have to look at the stroke risk. You have to look at the bleeding risk, and then give your recommendation. Of course, the triple therapy can go up to a month based on some of the data I'm going to show you later. So there's a variation from 1 week to a month, or hospitalization to a month. There's the triple therapy for 6 months for those with the high ischemic risk but a low risk of bleeding. And there's the dual antithrombotic treatment from the beginning or from after the triple up to 12 months, and then monotherapy with oral anticoagulation for after 12 months. So this is the paper that I referred to you earlier, and the review published in JACC. And basically the authors, who are key authors of all the papers published in this area, and this is their recommendation. This is not a guideline, but it's a group recommendation, and they looked at European perspective or practices as compared to the North American practices. And you can see consistently, you know, if you look at the, I don't know the color here, the kind of bluish oral anticoagulation should start from the start. So all AFib with PCI, they need anticoagulation all the way through from the start. So all the different subcategories that you face, they will need oral anticoagulation. And then the clopidogrel, they will need it for at least a year. And the question becomes, for how long would you keep them on aspirin? So if you look at the European perspective, they would go, you know, if the patient is a high bleeding risk, you know, very short period, maybe a month, a week, a month, and then up to 6 months, depending on your clinical judgment. If you believe that the patient is a very high ischemic risk and the bleeding risk is low. On the other side, this is the North American, and the differences is around the clopidogrel, say, for example, they may some of the experts would recommend continuing it beyond 12 months in high risk ischemic risk patients with the low bleeding risk, and then the high bleeding risk, low ischemic risk, of course, the same as we saw in the European perspectives. So in conclusion, NOAC should be prioritized definitely over vitamin K antagonists. So this is a strong conclusion out of those trials, and I don't think there is a lot of doubt there, except of course if a patient needs anticoagulation for a different reason, not AFib. The optimal timing for the transition from triple to dual antiplatelet, which is dropping aspirin, is the challenge. And this should be probably individualized given the clear trade-off between bleeding and benefit risk. And then compared to triple therapy, double therapy with oral anticoagulation, P2Y12 antagonist reduces the risk of bleeding. We saw that in all the multiple trials and the systematic analyses. So all trials performed so far were not sufficient to look at ischemic events. So it's all safety and bleeding designed trials. And the final conclusion is that you have to use your experience, and a tailored approach should be considered when you're deciding the best regimen for your patients in terms of what drugs to select and the duration of those medications. Thank you so much, and that's what I have. And if there's any questions, we'll get them to the end of the session, I think.
Thank you, Dr. Abdel-Majid. We'll have a discussion at the end of the session. Next speaker tonight is Dr. Mohammed Magdi, who is head of electrophysiology at Qasimi Hospital and deputy head of cardiology at Qasimi Hospital. He'll talk about anticoagulation in high-risk patients.
Thank you, Dr. Wael, for the introduction. I am really honored today to share this panel discussion among Dr. Abdel-Majid and Dr. Wael Mahmoud, and to address the case approach scenario for high-risk patients with atrial fibrillation and how we are approaching such issue, especially in the high-risk group of patients. Let me just share. You can see my screen now, right?
Yes, go ahead. You just put a slideshow.
Perfect. This is my disclosures, and I like always to start this with the Gulf SAFE trial, because I believe this is one of the prestigious trials that we have from our region, because before prescribing medication for our AFib patients, we have to know actually our patients, what is the criteria and the characteristics of our patients, especially for the high-risk group. When you look at the analysis, you will find that our patient mean age is 57, which is younger than patients in Europe and in the US, almost 10 years younger. You can see that 30% of the patients, they suffer coronary artery disease. You can see that 30% of the patients, they are mostly diabetics. 10% of the patients, they underwent stroke, and more than 30% of the patient, they had permanent AFib. So when you look at this criteria, you know that in our region, we have patients who are actually high risk group and even younger. This is very interesting when you look at this analysis for our region. Before 2009, we had warfarin and aspirin, as Dr. Abdel-Majid was just describing. I believe during that time, prescribing medication was easier because you didn't have much options, but it was more dangerous, as you saw from the trials and from the studies. From 2009 onward, we have different molecules coming on board, like the dabigatran, Riva, apixaban, and endoxaban. So those medication, you can say they had some sort of paradigm shift of our way of management, looking for our patient and how we are prescribing the NOACs for our patients. And when you look at the different trials, and I encourage you to look at the different CHADScore scores included in such trials, it's very interesting because you can have different diversity. Some of the trials, they had equal share of different CHADScore scores. Some of the trials, they had more high-risk patient groups. So this is very interesting when you look at the subgroup and sub-trial analysis, how we are approaching those patients and try to match them to our patients at the clinic while we are prescribing such medication. And I will encourage that we, for high-risk group patients, tricky patients, to have a multidisciplinary approach. So I recommend not to take only the decision by one person, but we can share experience. Like for instance, when we have a case which is very complex, like the case that Dr. Abdelmajid shared with us, we have actually a group team discussion with interventionists, electrophysiologists, even internal medicine. Sometimes we include gastroenterologists depending on the patient risk, and we start discussion what is the optimal therapy for this patient. I remember yesterday I got a phone call for a patient who was 65-year-old. This patient, she had a high CHADScore score, high HAS-BLED score. She bled several times, and we were discussing because she had two strokes before, and we want to protect her, and at the same time she's very high bleeding risk, and actually she bled. So we had a multidisciplinary discussion how to approach this case and how to prescribe medication for such patients. So this is very interesting and very important while making the decision for prescribing anticoagulation. Of course, now I think all our audience who are hearing me now, we reach to a settlement that NOAC is the best option regarding systemic and stroke prevention compared to warfarin. I don't think we need to discuss this anymore because I know warfarin is our punch bag, but this is actually established. Just think about the other way around. If we had the NOACs before 2009 and warfarin came 2010, for example, I don't think it will be even FDA approved or having a CE mark. When you look at the efficacy and outcome, it's quite good as well in the prevention of hemorrhagic stroke compared to warfarin. And when you look at the all-cause mortality, also it favors NOAC in compares to warfarin. So look at our patient that we're having today. He's a 69-year-old patient. He had stroke, AFib onset 3 years ago. He's a diabetic patient, and he has uncontrolled hypertension on beta blockers and diuretics. His CHADScore score is 3. His annual risk is 4.6%. He was put on warfarin during that time before he was referred to us, and he had bouts of dyspepsia and very frequent gastric upsets. And this is very important in the decision making as well. So this patient, he has recurrent attacks of angina despite of the medication that he's receiving. So the decision was made that he should undergo coronary angio, and it showed a lesion which was 85% and necessity stent deposition. At the same time, this patient has a moderate renal impairment of creatinine clearance of 46 milliliter per minute. So you can see how complex is this case, not only on the ischemic burden, but the renal burden, diabetes and hypertension. So it's quite a complex approach. So this patient is diabetic, hypertensive, renal impairment, and he has recent coronary stent, as you can see, and he has dyspepsia and gastric upsets. And from our observation in our hospital, especially in elderly patient, we have more than 30% they are diabetic, and half of them they are having diabetic nephropathy, and this eventually leads to the need of dialysis. So this is very crucial in the decision making, not only the decision making, in the follow-up of patients as well, because you know the patient is a dynamic process. So you will look for the choice of therapy that you recommend. I hope when you look at this slide, the first 3 options will not be an options anymore. So warfarin would be omitted. So the decision which strategy and which NOAC we can prescribe for this patient. I thank Dr. Abdelmajid for making it clearly and make it much easier about the probability while showing the Augustus trial into depth and into details, and describing and showing the how to select the proper dual versus triple therapy for those patients. So going back, this is the guidelines. So the guidelines recommended the use of NOAC in preference to vitamin K antagonist, and CHADScore of 2 or more in men, 3 or more in women, and it necessitates to assess the bleeding risk score, the HAS-BLED score, and to monitor this, because we have modifiable factors, as you all know, that needs to be monitored, because the patient, as I mentioned, is a dynamic process, and all of this can change and can be reflected on the bleeding risk score. So when you look at our patient, he's hypertensive, he has abnormal renal function, he had labile INR, he's above 65, and he has drug intake of antiplatelet. So this patient, his HAS-BLED score is 5 or more. So he has a high bleeding risk of more than 12.5%, which is quite high. When you look at the modifiable risk, that's why we are monitoring our patient, and the more elderly the patient and the more risk of the patient, some of our patients, we are monitoring them on regular follow-up every 3 months, not every 6 months. Because of this, we have to monitor the renal functions, the hemoglobin of the patient, the body weight of the patient, the creatinine clearance of the patient, because all of this can modify the dosage that we are prescribing for our patients. So hopefully we can modify something before reaching a complication or a problem that can happen. This slides was shown by Dr. Abdelmajid. I will not go over it, but if we consider our case that I just presented to you, our patient would be a high bleeding risk patient. So we are concerned about the thrombotic event, but at the same time, he has a quite high bleeding risk. So I think during the discussion, we can ask Dr. Abdelmajid for the recommendation for our patient if we start dual therapy for the first 6 months, and we can carry with NOAC afterwards for later on as a single therapy. Because if he agrees with me, this patient is a high bleeding risk patient, and I think this was elaborated with the repeated trials that we have, like the Pioneer, Dual, and lastly the Augustus trial. And it was mentioned clearly in the guidelines as recommendations for using dual therapy for those patients with high bleeding risks. So how we would choose our NOAC, like for this case? This case, he has atrial fibrillation, and he has a 5-fold increase in the risk of stroke. This patient has a moderate renal impairment, and this is an issue. And believe me, the most tough cases when we prescribe NOAC are patients with renal impairment or patient on renal dialysis. Um, all other comorbidities, you can find a solution. You could find the NOAC with safer portfolio and compared to the other NOAC in case by case according to the analysis. But when it comes to renal failure patient on dialysis, when it comes to patient with renal impairment, especially severe renal impairment, we have to take more time and more analysis before just prescribing the medication. I believe this is the most more high-risk patient, especially in our region. Renal impairment and diabetes, they are co-mixed and combined. It's quite unrare to see just renal patients impairment without diabetes. So this mixture, having AFib, diabetes, and renal impairment, this is a high-risk patient. So when you look at the meta-analysis and repeated trials addressing this issue for the NOACs, either with or without diabetes, we have 4 major randomized controlled trials, over 22,000 cases with a mean follow-up of 2.3 years, which is quite acceptable. When you look at the DOACs, they are associated with lower hazard ratio for stroke and systemic embolization compared to warfarin in diabetics and in non-diabetics. So I think this issue was clear now. When we are talking about whether diabetes or non-diabetes, NOAC's proven to be more effective than warfarin regarding this worried about how to manage a diabetic patient with atrial fibrillation. And when it comes to measure bleeding, it's not inferior to warfarin as well. So regarding the bleeding issue, we don't have much concern. But from our experience, and I think we need more trials addressing the issue in renal dialysis patient. I know in the American guidelines, in renal dialysis patient, they mentioned in the guidelines that you can prescribe warfarin and you may consider apixaban for such group of patients. But I believe we need more and more trials to ensure the safety in the dialysis patients, especially this category, that it's quite often that they have atrial fibrillation and they need anticoagulation as a prevention for atrial fibrillation. And from our follow-up such a group of patients, I will not say there is a huge number of patients, but some of those patients, upon follow-up, we needed to put for them left atrial appendage occlusion, for instance, because they had some bleeding. We have a patient who's actually relatively young. He's 55-year-old, but this patient, he had multiple comorbidities. He had high CHADScore, he has high Hasbled score, and this patient was receiving anticoagulation, and at the same time he had recent stent. So actually he was on dual therapy, and in spite of the dual therapy, he had bleeding. And because of the bleeding, it was repeated twice. This patient, we decided that we will put left atrial appendage occlusion for him because we didn't have any other option. But again, those patients, it's not the trend or the common case scenarios. Our center, we are putting on average per year around 12 to 15 left atrial appendage occlusion per year. So you can see that maybe you will face one case per month that will necessitate something like this way of management, which is class 2B in the guidelines, but it's not, thank God it's not common, but that's why we have to discuss and we have to make sure that we are choosing the proper choice for our patients. When you look at the meta-analysis for the ischemic stroke embolization, you will find that the bigger trend came regarding the prevention as number one, and apixaban came in second. And when it comes to the major bleeding, again, apixaban came as a safety profile in prevention of bleeding in the subgroup meta-analysis for such patients. So the network meta-analysis showed that the bigatran was the most effective for the outcome, followed by the apixaban, and indoxapan and apixaban were the safest for those patients to prevent the outcome of major bleeding. So I think everyone agrees now they are safer than warfarin, and they are effective in prevention of stroke and systemic embolization. And looking at the protection of the cardiovascular death in patients with diabetes, when you look at the NOACs that we are having in comparison to warfarin, when you look at the cardiovascular death, the results favoring all the NOACs in compared to warfarin. So I don't think anyone who is listening to me right now will deliberately prescribe warfarin for a patient who is having high risk of stroke while he has the privilege of prescribing NOAC. I hope you agree with me. But when you look at the renal, I believe this is the most, I know we are discussing diabetic patient, not diabetic patient, but I think the renal portfolio, it's very tough in decision making. This is very important. So if you're not convinced from diabetes, let's see what we have for the diabetic, the renal patients, as because you know, in our region, this is a major issue because it's associated with diabetes and diabetic nephropathy. So before going into the trials, look at the safety profile and the renal excretion of our NOAC. Here you have dabigatran, higher renal excretion, 80%. You have apixaban, 25%. You have Riva, 25 to 30%, and you have indoxaban, 35% renal excretion. So we should know the different types of renal excretion and renal safety profile, because this makes a huge difference during prescribing. Because if you have a patient with a lower creatinine clearance, for instance, dabigatran will be out of the picture, of course, because it's 80% renal excretion. So this is very important to keep in mind while we are prescribing the NOAC. When you look at the renal preservation trial outcome, looking at the NOAC and the effect on the decline of the GFR, or doubling the serum creatinine, or kidney injury leading to kidney failure, guess what? Again, NOAC takes the upper hand. So NOACs were associated with no decline in the GFR, or doubling the serum creatinine, or having acute renal injury compared to warfarin, which is very interesting and very reassuring when you're prescribing the NOAC for this sub-entity of renal patient. But as I mentioned, the more deterioration of the renal functions, we need more trial. And again, this is the real world evidence confirming the renal function is maintained with patients receiving NOACs. Because when we prescribe drug, we want a safe drug, and at the same time, we want to preserve the kidney. We don't want the kidney eventually to be deteriorating. And this is a trial that's showing so that there is a preservation of the renal functions when we prescribe NOAC, on contrary if we prescribe warfarin. What is the problem that we are facing worldwide? It's happening. It's not only in the UAE, and from my experience from the referrals that we are getting, it's the underdosage. The underdosage, and I'm not sure, I think we have Ahmed Hussein on board, and he's hearing me right now, that it's happening a lot. I think because we have apixaban 2.5 and 5 milligram. So if someone who's prescribing NOAC for a patient and he's fearing the bleeding complication due to any other criteria, and not following the criteria of having 2 out of 3 criteria provided from the studies on apixaban, so they are under dosage. So they are prescribing 2.5 because the patient has impaired creat, but the patient weight is good. It's above 60, and the patient age is less than 80. So actually, you should prescribe 5 BID, not 2.5. But sometimes, as a physician, you are fearing, because you know there is a famous word that I hear a lot.
If the patient had a stroke, it's because of the AFib. But if the patient had bleeding, is because of the medication that I'm prescribing. So this is the feedback that I'm getting. But anyway, we should know that if we are prescribing underdose of the patients, we are not protecting the patient. And the patient, if he has tendency to bleeding, he will bleed as well. So we are not doing any good for this patient. So by this slide, I encourage not to underdose, just follow the recommendation and the guidelines and prescribe the proper dose of the patient. So if the patient is indicated for 5 milligram apixaban BID, this should be the dose. We should not tend to reduce the dose to 2.5 unless it's indicated. So when we go again to our patient who's diabetic, hypertension, renal impairment, moderate renal impairment, recent coronary stent, dyspepsia, and gastric upset, I think when you look at this, like having diabetes, hypertension, moderate renal impairment, when you look at the moderate renal impairment with the NOACs that we are having on board right now, I think we have the decision between apixaban and Riva because of the lower renal excretion. We have a recent coronary stent, and this patient is high bleeding risk, as Dr. Abdelmajid nicely presented how to approach this patient. This is a high bleeding risk, so I think we will start with dual therapy. So a patient will take colbidogrel plus NOAC. But this we have to respect. When you have dyspepsia and repeated gastric upset, certain NOACs, they have tendency to certain sites of bleeding and predisposition. So when I find repeated dyspepsia and gastric upset, I tend to run away from the Decatran and Riva, because if the patient is suffering dyspepsia and gastric upsets, it definitely will be more when we prescribe something like the Riva and the Decatran. It's not reported that this can happen with apixaban. I'm not saying only one molecule is best, but I am saying that different molecules have certain tendency according to the patient. So you have to review the patient and choose the ideal NOAC according to the patient. So don't prescribe a NOAC that has more tendency towards GI bleeding or gastric upset. We tend to run away from those category of patients. And as I mentioned, if you're gonna choose, just choose, take your time, no rush in taking the decision and writing. And we should always have a multi-disciplinary approach while we are doing this, because I believe it's like a teamwork. So if we have the input, like if you have the privilege that you have someone experienced interventionist in anticoagulation, and at the same time in intervention like Dr. Abdelmajid or Dr. Walim Mahmoud, you can sit with them and you can discuss the case and give them the input, and you can come with a consensus together, which is a proper NOAC and how we're gonna follow up this patient. At the end of the day, there is no wrong answer. It's the matter of selection, the proper medication for the proper patient. And the more important is the follow-up of the patient, how we are following up the patient, because I mentioned patients, they are dynamic process. It's not a static process. And I would like to thank you for your attention, and we can start taking the question according to Dr. Wael while he's moderating the session. Thank you so much.
Thank you very much, Dr. Muhammad and Dr. Abdelmajid. We are open now for questions and answers. Please put your questions on the chat. We have one question only so far from Dr. Amanat. It says Toronto. I'm sure he's not watching from Toronto, but maybe he is. There is a Mayo Clinic study that showed better efficacy of dabigatran in females over 75. Which DOACs do you recommend in this group? I'm not aware of that study, but any of you aware of the study?
No. 75
I'm not sure about the study. So while and Dr. Manat, I mean, elderly usually is a challenge, and as you can see, and when you're assessing the risk of, especially the risk of bleeding, it's their renal function is sometimes, even if it's normal, it's a dynamic. The risk of fall, the risk of especially in the PCI group, in the AFib, PCI group, they are more calcified vessel, more diffuse, more, more multi-vessel PCI. So, their risk of thrombosis is high, and at the same time, the risk of bleed is very high. I'm not sure if there is any head-to-head, or sorry, if there is any comparison or any of these studies that looked at elderly population. So that's, I don't think there is a study that looked at dedicated for that special age group, maybe about 70 or 75. And even in the trials, I mean, usually elderly, like the patient that I presented, the 75 or 75 and above, are usually under represented, like other minority groups, which makes it even more difficult for us to make a decision. And that's the time I think you have to weigh, which anticoagulant you're going to pick. Dr. Mohammed talked about, the risk of GI bleed versus the risk of, like with, say, for example, with dabigatran, and also the risk of renal function deterioration. So all those factors, I think, needs to be considered, but I'm not sure if there's any good data that talks about a specific NOAC in this age group. And maybe in the prevention of stroke, but on the other side, the bleeding risk is a challenge. I need to see that paper from the one reference. It would be interesting to see how how the methodology and how good was the study was conducted. I don't know, Dr. Mohammed or Dr. Weil, if you have any.
No, I don't know.
No, as well, I don't know any. I'm not aware of this study.
This week I saw 2 patients with LV thrombus post-MI.
Right.
What would you do with them, Dr. Al-Majid?
AFib cases with LV thrombus?
AFib cases with LV thrombus, yeah.
And they were on anticoagulation.
So they're not AFib cases. They're sorry, they came in with STEMI, and then they were late. They were late presenters, and they had LV thrombus. How would you approach that?
Still, I mean, the same thing. I don't know if there is a good data on NOACs and LV thrombus. I mean, most of the trials that we talked about, either in the setting of a PCI and a post-MI, are mainly in patients who who had non-valvular atrial fibrillation. Other indication for anticoagulation was an exclusion for the majority of trial, like mechanical valves or valvular, like mitral stenosis. So again, the same thing, it's a challenge, when it comes. Of course, I mean, this patient is not atrial fibrillation; it's just an LV thrombus patient, right?
Yeah, LV thrombus with a stent. So I mean, the data isn't there, but we just used an antiplatelet and warfarin.
Yeah, I mean, if the patient is at the low risk, I mean, I would, if I'm going to go with the warfarin, definitely, if the patient is at low risk of say, coronary event, a large stent, short stent, single lesion, atherosclerotic burden is not large, or it's not, it's not high, then probably these patients at low risk of coronary event. So maybe I'd go with the warfarin and clopidogrel, and that would, the risk of bleeding would be low compared to triple therapy, and at the same time, the risk of having a stent thrombosis or a coronary event would be low. The challenge is going to be if the patient is having a high risk coronary thrombotic risk, diffuse atherosclerosis, multiple PCI or multi-vessel or a bifurcation stent or a calcified vessel or long stents. then it becomes a challenge as to for how long will you go triple therapy and how aggressive you're going to go after their anticoagulations. If you go with the warfarin, how frequent you're monitoring it, and I would try to keep the INR as on the lower side. Let's say 2 to 2.5.
And the mechanism of possible stroke here is completely different because we are addressing a patient without atrial fibrillation. This patient has an LV thrombus. So I think, as Dr. Wael mentioned and Dr. Abdul Majid, we don't have enough data supporting what we can use. In different meetings, I read some papers and I attended some sessions that they used NOACs for LV thrombus and they showed promising results. But for the time being, we don't have recommendations. Especially this patient, he doesn't have atrial fibrillation from the beginning. So this is an LV thrombus. But some of the trials was very interesting that showed early LV thrombus, actually it dissolves much more faster and quicker. So the patient, if you brought him for follow-up, after 1 month or 6 weeks, you might not find anything. So from your expertise, I think you observed this as well, correct?
I mean, yeah, I've seen this before, but the guidelines are to put these patients on 6 months of anticoagulation. I mean, within 2-3 days, you're absolutely right. We had a patient, one of the patients that I'm talking about here was transferred from one of the hospitals. He had a thrombus in the LV. And then when he came and he had a stroke, that's why he came to us. And then when he came to us, we didn't see any thrombus in the LV, And he was also post-MI. So a very difficult case. I don't know about you, but in my experience, triple therapy is not a very simple thing to do. I haven't seen, thank God anyway, I haven't seen any stent thrombosis on double therapy, but I've seen some pretty bad bleeding problems with triple therapy. What is your experience?
I agree with you. I mean, triple therapy usually is not the best. I mean, when we prescribe it, usually, as I said, it's assessing that risk. And usually, when I see a left main stent, a bifurcation, when I feel that the results of the PCI is not optimal because of, say, diffuse calcified, all those different factors, patient who presents with a heavy thrombotic burden, like a STEMI patients, so I look at all those factors, and if I go with it, usually I strongly advise of close monitoring to ensure that that the patient is, if there's any bleed, especially, GI bleed is detected early. So more aggressive surveillance and monitoring of this patient, and try to ensure that it is shortened as much as possible. So you want the stents and to heal at least for, you want to give them some time, at least a month minimum of that triple therapy. Of course, I mean, the bleeding risk is high based on any of those, on the factors presented in the different, all the different predictors of bleeding that we saw on those different trials, or out of those different trials, and the risk and the risk scores and the bleeding risk score. So if you feel your patient has multiple risk factors for bleeding, then I would lean towards a more conservative approach, which is a dual antithrombotic therapy. And again, I mean, I would try to avoid the ticagrelor and go with the clopidogrel. So it is a tough decision, and that's why, Dr. Wael, you see in the guidelines, I mean, you see that state-of-the-art paper published by Capdano and Jack. The authors themselves, they come from the European and the Americans, and you see a variation in the recommendations around the duration of the triple therapy. Some are very, very conservative, and they want to keep it for a week, or the hospitalization only. And of course, after the risk assessment, but some, they pushed up to 6 months if they believe the risk of thrombosis is very high. It's
With
tough.
the newer stents as well. I mean, you're dropping the dual antiplatelet therapy now from 6 to sometimes 3 months in some cases, particularly if you want to take a patient to surgery. So,
Right.
you know, there's more data to go with shorter periods of dual antiplatelet therapy, particularly with the newer stents.
Definitely, yeah. I mean, if you look at stent thrombosis in some of the most recent trials on the new platforms of stents, the ultra thin struts, with all the different advancements in optimizing the procedure, the PCI itself, the stent thrombosis is very low. It's down to 0.3%. But I mean, again, this is the data or patients who are randomized in trials. So the real, again, the decision is, in real life sometimes can be different. We all see the patients who are not compliant. We see the patients who cannot afford. We see the patients who, who whatever you explain to them about the risk, they don't understand and they stop their medications. So those who stops it because of procedures that they have to. So, the risk of stent thrombosis definitely with the new advancement in stent technology and advancement in procedure is very, very low. I mean, it's down to reported in one of the recent trials down to 0.3% with some platforms. So it is low, but that's not the only factor. I think there's still other factors that we have to consider when we're making our decisions.
I want to shift to devices. Some people think that devices are a solution. And Dr. Muhammad, you have a lot of experience in left atrial appendage devices. But please explain to the audience here that you need to be on anticoagulation of some sort for at least 6 months. So it's not as if, you put in the device and so maybe you can say, tell us a little bit about your experience.
Yeah, first of all, we wanted to make it clear that putting appendage occlusion is not alternative to anticoagulation. So it's not like I'm giving option to the patient. Instead of giving, wax or warfarin, I will occlude the appendage and that's it. It's not alternative. It's for patients who have either high risk for bleeding or actually bled. And we are more in our hospital on the conservative side of using the appendage occlusion. So you will find almost 90% of our cases, they actually bled because of anticoagulation. And as I mentioned, we are doing on an average 1 case, 1.5 per month, like 20 per year. It's not a huge volume, but for the high risk population and patient who have bleeding. For the strategy following the LA appendage occlusion is changed. So in the past, I totally agree with you. The recommendation was for 6 weeks to give anticoagulation, followed by antiplatelet therapy for 6 months. But now with the new devices that we are implanting and with the trials like the Aspirin Plavix feasibility trial, we are not giving any more anticoagulation from day one post-device insertion. We are giving either dual antiplatelet therapy for the first 3 months, followed by single antiplatelet therapy for 6 months, and that's it. And if the patient is at a high risk, we are giving only single antiplatelet therapy like clopidogrel for 6 months, and that's it. So we shifted from giving anticoagulation with the new devices that we are using, like the Watchman Flex device or the Amplatza device from Abbott. So we are not prescribing anticoagulation anymore. But again, we should be conservative. It's 2B, class 2B in the guidelines, and it's not alternative to anticoagulation, because just imagine, Dr. Wael, we are getting lots of referrals that patient he has atrial fibrillation, the patient, he should receive anticoagulation. Why not to put appendage occlusion for him? So actually, I spend more time with the patient, because the patient, when he comes preconditioned, especially if he's anxious to have anticoagulation, to convince him this is not alternative. This is in case, God forbid, if you had an event or according to your HAS-BLED score. So this is very important to keep in mind. I think
when I meant anticoagulation, I totally agree with you. I meant really dual antiplatelet therapy, which is sometimes the bleeding risk as bad as anticoagulation. So you're going to have to give dual antiplatelet therapy for a short period of time.
Yeah, for high risk, we can give single. We can give only clopidogrel for 6 months, and that's it.
I think only with the Abbott device, but with the Watchman, you have to give dual.
With the Watchman Flex device, which is the new release device, and the
I don't know
study
the
would.
new release.
Yeah, it was launched in the UAE only last month, and we did the first Watchman Flex case, which is a very nice device, much easier than the previous Watchman device, which was more complex. The recommendation, you can use a single or dual antiplatelets according to the patient risk stratification for the patient.
Abdul Majid, you have some experience in TAVR. What about the role of, what do you do when you get a thrombus in one of these TAVR cases? What is the current guideline? You are muted. Abdul Majid, you're muted.
Yeah. So, our routine, of course, anti-platelet treatment is, we still give, I know there's ongoing trials on, but aspirin and still we give aspirin clopidogrel for 6 months. But with the, with the AFib, I would go with the same, the dual, the clopidogrel and a NOAC, depending on, of course, on the patient, but dual therapy, and then stop the clopidogrel in 6 months. They, I mean, the risk with the TAV is, the valves. Of course, there's differences across the different valves. But there is this, there's some CT data that shows that there's, some thrombogeneity of the valve itself, that, that some microthrombi are attached to the valve, that you need that antiplatelet therapy. But yeah, I would give a 6 month a treatment of clopidogrel and one of the NOACs for, of course, for life, for the AFib. That's my question, I guess, Wael.
Yeah. I want to come to another issue, which unfortunately is still a major issue. And Dr. Muhammad, you pointed to this, and this is the inappropriate dosing. We recently published a paper in our center showing inappropriate dosing is up to 20%, and that's in a tertiary center or quaternary center. Just imagine what it is outside in the private sector. I'm sure it's much higher. And we've seen it with all the medications, obviously. And I think maybe you can comment on how important it is to actually give these patients the right dose.
Yeah, this is a major problem, as I mentioned, because if we underdose, actually we are not protecting the patient, so as if we are not giving the patient anything. And I think this is worldwide. I think there was a publication from the US, Dr. Wael, they had a 30% underdosing as well in major centers. So this is a very common practice happening, especially if you are getting referrals from like some of the distant centers, like small centers. They are prescribing to be like as if to be on the safe side. They always say if the patient got a stroke, it's from the disease. If he got bleeding, it's from me. So that's why they are very, let's say, like reluctant to prescribe the proper dose. And I think by the webinars and the meetings and highlighting the importance of giving the patient the proper dose, this will be solved eventually, hopefully.
You talked a little bit about renal dysfunction.
Yeah, major issue.
What's the role of apixaban in renal dysfunction, and how low with the GFR would you go?
This is what I was mentioning in the guidelines, and I think there is a question addressing the end-stage renal disease patients on dialysis. Someone is asking this question, how safe and do we have enough data to reassure? In the American guidelines, they wrote, you may consider. So they said warfarin, and you may consider apixaban. They mention it clearly. But I think we need more data. Dr. Wael, we need more randomized controlled trials involving those patients. I know that we had some trials were running, but there is no clear feedback on end-stage renal disease and severe renally impaired patients. Still, for the time being, for renal impairment patient, we tend not to go below the recommended creatinine clearance 15 milliliter. If below, we cannot go to prescribe like the apixaban or rivaroxaban because of the low renal excretion. Definitely will not prescribe the ligatran because of the high renal excretion, but still for this category of patient, this is the most challenging cases. Most cases who suffer problems with warfarin or NOAC, those patients with end-stage renal disease and on dialysis, they had some form of bleeding. We had a patient who had repeated gum bleeding, leading to anemia because of the repeated gum bleeding, as simple as gum bleeding, and some patient they had GI bleeding. So I think we need more trials. They didn't carry on with this trial. I don't know what happened with this trial. I know that they are running more trials to address this issue, but I will be totally honest. I'm not fully confident in patient with end-stage renal disease on dialysis to give him NOAC or warfarin, because just imagine if we just spend the last hour saying NOACs, they are safer than warfarin. And then we are saying we are not sure 100% in this group of patients to give NOAC, how we will be sure as well to give warfarin. So the NICE guidelines in the UK, they address this category that you have to calculate the bleeding risk and the stroke risk, and you have to have a family consistency. You have to sit with the patient and the family and to discuss with them the risk of stroke and the risk of bleeding, and we have to involve the patient in this discussion, because the patient, if you didn't give him anticoagulation, he might have stroke, and if you give him anticoagulation, he might bleed. So this is an issue, and I will be as well honest with you. That's why in such high-risk patients, if I have a patient with CHADScore 5 or 6 and has bleed score more than 5 or 6, I will have like up into my mind the left atrial appendage occlusion if there is no contraindication handy just in case for this patient is an option.
Yeah, it's very difficult to deal with the end-stage renal disease, and as you said, warfarin is no safer than NOAC. There is some promising data using apixaban in patients with renal dysfunction, sub-studies, but no prospective randomized, I think, up till now. Just remind us, somebody's asking here, just remind us what are the criteria for the low dose apixaban?
So we have to have 2 criteria out of 3. So it's according to the patient age. So it's ABC, age, body weight, and creat. So if the patient age more than 80, this is 1. If the patient body weight less than 60, this is 2. And if the creat is more than 1.5, this is 3. So if we have 2 out of 3, this is indication for the low dose.
Yeah. Okay. Is there any new data on the new Andexa? Does anybody know about Andexa? I don't know what Andexa is.
I'm not sure. Maybe he's asking about the Antixinate alpha, maybe, and the antidote. Maybe I'm not sure if he's asking about the antidote.
I'm not sure what he's asking about.
Or the edoxaban.
Maybe edoxaban.
Maybe.
Yeah.
I don't know what's edoxaban's.
I'll have to look at the studies. I had ignored all the studies previously because I thought it was just going to be in Japan.
Yeah, exactly. No, they're getting it in the market. So
yeah.
Soon you'll see that.
Any other comments? Oh, he's talking about Andexa, the antidote for factor 10A inhibitors.
So I thought he's talking about this, the Antixinate alpha for antidote.
Anti-10A.
If I may, I will say something.
That's not available here, actually. We don't have it here yet. Correct? We have the antidote for dabigatran at the moment, but not.
Yeah, exactly.
Yeah, I mean, a number of hospitals bought it, but I don't know how often. It's been used once or twice for severe intracerebral hemorrhage. And it's interesting because a lot of people were asking about antidotes. So the antidote for dabigatran anyway was available. And it hasn't really increased the use of NOACs. So I think physicians were making that as an excuse. But I don't think the anti-10A is available in the market yet, is it? I don't think so. No, I haven't
No, I
seen
don't
it.
I'm
think
not
so.
aware.
No. The Bigatran, yes, we have it, but we never used it. We didn't
Yeah.
use it, but andexanate alpha we don't have.
Yeah.
We had a major bleed because of that. We could not get the get that.
It's not in my understanding, it's not available yet. Yeah.
We had a patient with a major GI bleed a year ago, and it wasn't available at that time.
Okay, I think we're coming to the end. There's no more questions. I'd like to thank
Great.
Dr. Mohammed Magdi and Dr. Abdul Majid Zubaydi
Thank you.
and the Emirates Cardiac Society and Pfizer for setting this nice program. I hope you enjoyed it and hope to see you in future webinars. Thank you very much and good night.
Thank you.
Thank you.